Hello, and welcome to today's session on proposed changes to residential habilitation. Sorry, we're starting a couple minutes late. We just wanted to give folks an opportunity to join us. And I am Lynn Keilman-Cruz, the Deputy Director at Senior and Disabilities Services, and I will be doing the presentation today. I am also going to try to call out some credit to the individuals that took the pictures in my slide presentation. Mostly my husband, Boulevard Cruz, did all of the nature shots. But welcome to today. And so I wanted to start with the mission of Senior and Disability Services, and that is that the Division of Senior and Disability Services promotes health, well-being, and safety for individuals with disabilities, seniors, and vulnerable adults by facilitating access to quality services and supports that foster independence, personal choice, and dignity. The individuals in the photos graciously agreed to share their photos with Senior and Disability Services. And I think it's really important that we start with a picture of people, because we're all here about the people, because we all have the same purpose, and that is to serve or to be served well by the services that we deliver. So we all are looking for quality services. One slide on how do we engage with each other to make everybody's day, hour and a half together, engaging and successful. We are using a webinar platform, which is a little bit awkward at times. I will be presenting, and then we will be, this webinar is being recorded. And so when we do unmute the mics later in the presentation, we want to make sure folks are not including any names or specific health data of any cases that you might bring up, so that we can share this publicly and put it on our YouTube channel. So we are going to do this and put it on our policy YouTube channel so everyone can hear it later. And if you're putting questions in the question and answer box, you do that by clicking this orange arrow that I have posted here in the webinar itself. And there'll be some question and answers. I have folks on the line that are listening in that will help sort of answer questions as we go along if they can. But we will also unmute at the end, and you can let us know in the question and answer box if you would like to be unmuted so you can speak. We'd be happy to do that. We're really seeking your feedback today. This isn't, of course, your only opportunity to give us feedback. We always welcome feedback, and you can send it to this blue box at the bottom, the DSDS policy mailbox, and your questions will be cataloged and answered. So thank you for this picture was taken at Katmai, about 5 feet from this bear, with my cousin's iPhone. So we're talking today about these proposed regulation changes, residential habilitation changes, not regulation, I'm sorry, proposed residential habilitation changes included in our base waiver amendment. And I will talk a little bit about our language and the things that we've had to do to propose these. Tomorrow, September 21st, from 12 to 1:30, we will be talking about legally responsible individuals and the ability to provide service if you are an LRI in a certain set of circumstances. But we will not be discussing that today. That's for tomorrow. And then on Wednesday next week, between 12 and 1:30, we will also be talking about the adult host home, Senate Bill 57. And we didn't propose those in any kind of waiver amendment form, but we wanted to make sure that you were aware of that webinar, because we have a lot of work still to do before we even develop those services that are called for in Senate Bill 57. So please go in and register if you haven't done that, and come to those webinars as well. Then where can you find, whoops, I'm sorry, yeah, there we are. Where can you find these proposed amendments that we're talking about today? Those are going to be in this particular link. It's on our web page, and you can go to the bottom of that web page and you will see the IDD proposed waiver amendment, APDD, CCMC, and the ISW. So please use the link. We're only going to give you a high-level overview today of what's proposed for residential habilitation. And hopefully you'll have the time to go in, review the documentation in the amendment itself. And anything highlighted in yellow is the parts that we're really focused on that we've amended. So just be you know, thoughtful about that when you go in. You can scroll to the yellow changes if you want. The amendment itself tells you everything that's in the waiver. Going forward, we also have a couple of webinars that we are scheduling for November and December. We're not quite ready to talk about those. And you'll find that some of the things we'll go through today, they touch each other, and we're trying to be very thoughtful about what we deliver out so that we can focus on specific areas so we can get the best comments that we can get from you and allow people to sort of catch up to where we've been working at a very fast pace. So you will notice that the acuity add-ons, we've included some acuity add-ons, one for 2-to-1 24-hour acuity in specific circumstances. Another one we've proposed is a 12-hour acuity in specific circumstances, and an age exception for group home service for ages 16 and up in a very specific set of circumstances that would not be for every 16-year-old. Those services were requested in our Appendix K, which I will go over in just a minute, but I just wanted to make you aware we're not going to talk about these today. Those are going to be in November and December webinars. The other thing we've been working on at the division for seems like forever is the organized healthcare delivery system. And this is a new way or a very structured way of allowing family habilitation providers, rendering providers, to be connected to another agency that would help with the certification process and help with the payment structure, help with billing. And so we have been working with a national contractor and feel like we're getting closer to be able to deliver some information out so we can get a healthy dialogue going with stakeholders. And that will be sometime in November or December. So what I hope to gain or hope to give you and hope you can gain from today's webinar is really sort of some of the expected activities and outcomes for today are listed here in this slide. You will notice that within the plan overview when I talk today that we've had some very tight timelines that we've had to meet. And I want to be really transparent about the fact that we struggle internally at Senior and Disability Services with our own bandwidth issues. And we have a lot to do in the coming weeks and months to get all of these different elements enacted and implemented. Working together as partners and trying to give us as much feedback as you can is very helpful to us as we move forward. I also want to point out that we have not written any regulations for any of these proposed services. That will come later. There will be another public comment period for regulations. This is not part of that. Today, it's really just about telling you what we're proposing, getting your feedback, and we will have a little bit of time to revise that before we have to submit to our Centers for Medicare and Medicaid with the real deal with the base waiver amendment. So I wanted to kind of go over both the federal requirements and the state requirements for what we have to do when we implement a new service. And it gives everybody sort of an idea of all the parts and pieces that are moving kind of simultaneously to get us to a different proposed service. So one of the things is when we talk about the waiver applications and assurances under the 1915C programs, the 1915C program is an authority from the Centers for Medicare and Medicaid, CMS, which I will refer to as CMS. And we apply to them to be able to administer waivers in our state. So that is what we call the base waiver when we're talking about our application to CMS to ask for services. And we do that to implement our 5 waivers. Whoops, I'm getting handsy with my little control here. Sorry about that. So waivers, applications, and assurances, that's under the 1915C program. Then each 5 years, we have to renew all of our waivers. And so we have to look at all of the things that we've done in those 5 years. We make projections out for the next 5 years, and we answer a lot of back and forth with CMS about what we're doing in our waivers, what we, are the services meeting what we intended them to? Are we still applying the same policies that we asked for 5 years ago? The other thing we have to review every 5 years is our performance measures. And along with the performance measures comes the reporting of how do we capture everything that we do every day in our waivers and be able to report that back to CMS. So reporting becomes a big part of it. So under a disaster time frame like we had during the pandemic, we can apply for what we call an Appendix K, which is really asking for permission from CMS to operate our waivers with more flexibility or perhaps in a different way than we have in our base waiver. And so we've asked for flexibilities from CMS. And you will hear me call it an App K throughout my discussion today. I just wanted to be clear, it means the Appendix K under the disaster relief. The next, this slide is a sort of indication of all the state requirements we have to meet to change a service or to suggest a service. And so eventually we will do all of these things to be able to apply the proposed changes that we're going to talk about today. So we have to develop the state regulations, policies, the rates to make the payment for whatever service it is. We have to operationalize each of these. So we have to develop the forms, the processes, the training. We have to engage with the public like we are today. We have to engage after we've set the rules so people understand what we're asking them to do or what's offered in the new service. We also have to make updates to our data system. So if we develop a new service and we're going to pay at a different rate, we have to be able to develop that rate behind the scenes in our Medicaid management information system. We have to track it in Harmony and have ability to track it in Harmony. And we also have to report and track those things so that we can report out to whoever wants that information. And last but not least is our funding sources. So we always have to ask for authority to spend money, either from our legislature, the governor, or from the federal government. So everybody has sort of their own set of requirements. And it seems like, so I laughed to myself when I created this slide because it seems so clear. It's like black and white right there. But these things can take months to do. And I just want you all to understand that, we hear sometimes the frustration of how slow things move. We feel that same frustration, but it is something that we do and are required to do to promote fiscal responsibility, program integrity, so that these services, whatever we do, can be sustained going forward, so that we know we can afford them going forward and that they're going to meet the needs of the public that we serve. So some of our review of interactions with our federal partner, CMS, and sort of the history of where we came today and why we made some of the decisions we've made. I just wanted to go through that with you all so you understood sort of the baseline for where we started. So in March of 2020, we all remember that dreadful month when we were under the pandemic, and realized very quickly that Alaska needed to scramble to figure out how to keep people safe. We put together our first Appendix K really quickly within a matter of maybe a couple of weeks, and to seek permission from CMS to operate our waivers differently. And we have, you know, tried to be really thoughtful about what would we need to keep people safe during a disaster period. Since that time, we have submitted 9 separate Appendix Ks. So sometimes we forgot things, we wanted to amend things, and we'll get to our last one, which is really what the meat of this this presentation will be. We also renewed during this whole past few years, we renewed all 5 of our waivers, which requires an intense amount of work from all of us, especially in quality assurance and with our research and analysis team, to be able to report on the waivers, to go through all the performance measures, and to make sure that we're answering all of CMS's questions. And we were successful in all of those. They've all been renewed. And then, you know, really early, pretty much throughout, I put in early 22, but pretty much throughout the whole entire disaster period, we started realizing and hearing from stakeholders which flexibilities we could make permanent, or people had a desire to make permanent, and really which ones we couldn't make permanent under CMS rules. And so we started really examining that, and we put some things forward pretty early in 2021. Some of those things we amended and put into our base waiver, like distance delivery and things like that. So there were many things that we could include, and we did include. And we also thought about things that, you know, we wanted to include, but, you know, sometimes you just cannot. And then in August of 2023, CMS sent out a state Medicaid director's letter indicating that they would extend our APK flexibilities. So our APK flexibilities are set to expire in November of 2023. And we heard some rumors earlier than August that CMS might extend those if the state had a request in that they couldn't quite get dialed in with regulations and amendments to the base waiver, and we could submit something and they would extend the APK as long as we were moving to amend our base waivers. So in June, I believe Director Newman went to a conference, and in that conference, he was talking about complex care and how difficult it is in the state of Alaska to meet everyone's needs, especially individuals that have complex care needs. And, you know, CMS was there. They said, we agree, it's happening all across the United States. Why don't you think about your APK? Submit something to us, you know, think about that. So Tony came back, Director Newman came back and said, hey, what do you think about submitting something? And then he went on vacation and we submitted it. So we worked together internally to say, well, what is it we think we need? So we took this as an opportunity to get creative because we had been hearing a lot about very acute needs that were not being met or could not be met in our regular home and community-based settings. So institutions can no longer serve at some point, and our regular group home and family hab homes were being overwhelmed with these very complex individuals and didn't feel like, or weren't accepting people into the home, and for good reason. You know, we're dealing with a shortened workforce and lots of individuals that had been maybe institutionalized during the pandemic, and everybody sort of stayed in a setting. There wasn't a lot of movement during the pandemic. And so we're seeing a flux of those individuals now, and we're dealing with that across the state. And I think, you know, most stakeholders would recognize that here. So a couple of the things that we put into our Appendix K, which is asking for permission to do things a little differently, was to temporarily add specialized homes for individuals with higher acuity and complex needs. And basically, we said in that document exactly what I just told you, that we found that people could not be met with our existing services, and we needed to do something a little bit extraordinary to be able to provide extraordinary care for individuals with comorbidities or severe behavior concerns, or maybe with very complex health issues. So we know that these things were happening. So you might ask yourself, why submit an Appendix K with such a short time frame and so little time to amend the base waivers? And we just took it as an opportunity, though it wasn't, we didn't have time to engage with stakeholders. We didn't have time to go out to the public in general. We took what we had learned through the pandemic and from dealing with, you know, difficult, you know, situations for individuals that couldn't be supported, and we wrote something up. So that's why we did it, and we're hopeful that it is going to be a thoughtful and productive thing for our stakeholders. You might also ask yourself, why aren't all the APK flexibilities made permanent? When you look at all that list of the federal requirements and the state requirements, there are lots of reasons for that. We don't have the bandwidth to make everything from the APK permanent. Some things are not allowed by CMS to be permanent. So I'm not going to focus on that today, but I knew that question might come up, so I thought I would just let you know that it's not because of a desire and lack of desire. And we have looked a lot at our internal things that we did during the pandemic to see what we could push forward. So again, when I talk about Alaska's needs, I think, you know, stakeholders would be aware that we've had a lot of complex care committees. We had a complex care, you know, conference a while back between the Department of Health and the Department of Family and Community Services, and recognize that these were some of the two main items that we've heard loud and clear from stakeholders, is that we need more complex care options and we need to stabilize the workforce. As we go forward, or as we went forward, with the department split, it was evident that for us to have continuity of care for individuals that are affected by both all the divisions within the split, we the Department of Health and the Department of Family and Community Services got together and said, how can we ensure continuity of care for especially some of our more complex individuals that need different levels of support that we don't currently really have in Alaska, or maybe we're not aware that we have. And so let's put our heads together and figure out how we're going to serve people better. And one of the things they did was came up with a case review team. So every week internally, we meet with the other department to talk about specific cases. Many community members have been involved, care coordinators, providers, to give us information to know what can we do with these cases that need more support. And then the complex care committee was developed to actually look at a systemic level of what kinds of changes do we need to make. And that some of that work and some of that discussion is sort of what drove us to ask for what we asked for in the Appendix K, and also to propose what we put into our base waivers. The Complex Care Advisory Group has not really been formed yet, but that is the next step of this plan, is to gather people from the community to help advise how we deliver services in the state of Alaska. So excited about that work. It is a lot of work, and we're on the way. We're making progress. So what is in the Appendix K, the App K, submitted by July's deadline? So literally, Tony came back from vacation at the end of June, and we found out from CMS that they really wanted to have any Appendix Ks in by July 12th, I believe it was. I requested special approval to turn it in on the 13th because we were so close. So these are the types of things that we put into the Appendix K. We asked for a specialized family home habilitation to serve youth 18 and below, or adults in a family home setting. We also asked for a specialized group home habilitation. We asked for an exception for allowing group home service for youth 16 and older in certain situations, and additional acuity add-on options that I mentioned earlier. For the sake of this discussion, we're only going to talk about those specialized services. We're going to leave the acuity add-on and the youth 16 and older for a November topic. The base waiver amendments, they don't require quite as much specificity as we had earlier mentioned. So some of the things that went into the App K, we did not have to put into our base waiver, but we have to write regulations for that. And so we will be seeking feedback on that. But for this, these individual will be focusing on just the green bulleted areas today. So we did add the legally responsible individuals, LRIs, for residential habilitation, in-home supports, and supported living. And that discussion is happening tomorrow from noon to 1:30. So for today, we're only going to talk about these two. We're keeping this focus very narrow so that we have opportunity to get feedback. So the intent of the new proposed services really was to develop homes with highly skilled and trained workforce, establish some provider credentials that demonstrate experience and expertise in serving complex care needs, and to promote a setting for individuals that can't be served in our regular standard settings. This does not change existing group homes or family habilitation homes. Those will be continued to have the same credential, be certified the same way, deliver the same services. And though we recognize that our current environment serve all types of individuals with distinct needs, the new credential and service type will hopefully support individuals that can't be supported in our current service array. Providers wishing to become a specialized provider type would need to meet the additional criteria, and not all currently certified providers of group home and family hab will be eligible for that. And that's what we're going to talk about today, mostly. So the provider credentials for specialized family home habilitation, you know, these are the ones in blue are really the listed, those are the things that you have to meet every day to be a family hab home. And I'm just saying the criteria for child specialized family hab home for the age limits and the adult specialized family home. But these are the new requirements that we would ask for. So existing certified providers with at least 10 years of experience or accreditation. So we're looking for a very highly skilled service provider that has had years of experience dealing with complex care. We're looking for them to have a contracted licensed psychologist or licensed medical professional who has expertise and training in psychiatric behavioral health or mental health treatment, and has access to a contracted licensed registered nurse, and is able to provide that wraparound sort of service for heightened staff training in behavioral health techniques. We're really looking for building a very specialized home that would be a specialized service in a home that would be meet the needs of these individuals. That right now we have individuals sitting in hospital settings and are at API, and they're not able to find a home and community-based setting that can serve them. And that is a problem, and that's unfortunate, and that's what we're trying to solve for here. So I'm only listing a few of the things, so please remember you have to review the proposed waiver amendments to get the real full idea set of why and how we are the criteria we're proposing. And it may not be good enough. I mean, remember, we wrote these very quickly. We put our proposed ideas out there. That's why we're seeking your feedback. We really want to know what our stakeholders think about the services. You can find these amendments at this yellow orangish link here, and please go in there. Remember, the highlighted yellow sections are the ones that are the most important. So what we're really, in sort of a generic idea, is what we're really looking for is a family style home, maybe shift staff because of the highly acute needs of individuals served. So we understand that our normal family home is really a family, and oftentimes don't have employees and they don't shift staff because they're a family and they get paid like a family, and we expect them to sort of treat the member like a family member would, and give them that level of support. In this particular specialized home, we're looking for a higher, well, we're not looking for it. The demand of the individuals that need the support require sometimes someone at your elbow, I like to say, to be able to step in because their needs are very highly acute. And so that may take some more shift staff. And so we put a rate into our Appendix K, and that rate is very similar to the specialized group home service because of the requirements of shift staffing. That's really what we believe costs the agency the most money, is to be able to support and shift staff. We would expect this particular specialized family home, we would think that would be operated by an accredited agency or one with the required experience and the clinical staff to oversee and train. And so it wouldn't be your typical family habilitation home. It might look like a family style home, but it's going to have that wraparound support, and it's going to have shift staff. That's sort of the idea. We'd love to hear your thoughts on this, though. And maybe we're off the mark, maybe we're right on. Listening to other stakeholders, though, I hope we're on. And in what circumstances would a setting of this type support an individual? So it could be an individual discharging from an institutional setting. We have many of those ready and waiting for a place. And the person may experience acute behaviors, demonstrated need for behavioral interventions, and or has a documented history of repeated unsuccessful prior community placements. May pose an extreme risk to themselves or community without specialized services. And they're not able to discharge directly to home community or a family home because of their documented needs. So when I talked earlier about the case review team, our thought here at SDS is that this specialized home can't serve every type of person, because we really want this to be a specialty, because there are individuals, like I said, that are sitting in a hospital or sitting in an RPTC or Alaska Psychiatric Institute because they don't have a home. And so many of those cases are coming through that case review team, and it's clinical staff, often other areas, other divisions. We're all coming together to say, yes, this person, really has a high level of need, and we need to find a placement for them. So these are the thoughts we have about how we would approve a service for someone, and how we would give a provider a credential. But we really want to hear from you. Can you think of other circumstances this type of home could support? Do you see barriers to creating this type of service? And then what are those barriers? How do we carefully ensure choice and encourage independence so that if a person is able, they could move to a standard family house setting? And as with anything we try, it will need to be really carefully considered to ensure we're getting the right resources in place to support individuals at the right time in their life. So any feedback you can give us on this would be greatly appreciated. So I'm going to pause for a minute and give you some time to take a few minutes, put your questions in the question answer box. I have not looked at that at all, I'll be honest. I've been focused on my notes and my slides. So, at the end, as I said before, we'll respond verbally at the end, and we will also unmute phone lines for people that wish to speak. If you could identify yourself and wish to speak, and if you're shy, we can always get those comments later. You can send them to our policy mailbox. We're happy to answer questions there. The provider for credentials for specialized group home habilitation, basically the same type. It's just serving a different group of individuals, but the provider credential is the same. So you'd have to have the same certified experience or accreditation, have the same kind of high-level clinical staff available to you on staff, and provide that sort of wraparound heightened staff training in behavioral health techniques or complex care techniques if it's an individual with a complex medical condition. The group home itself, the service happens inside of a home with shift staff to serve individuals with highly acute needs. It would be operated again by that accredited agency. So we're looking really for an agency perspective where they have availability of staff, clinical staff, to help train professionals to meet the needs of the individuals in the home. And very similar circumstances would apply in this situation. Individuals discharging from an institutional setting, jail, or acute hospital, and mostly I was thinking about that for adults, but it could apply to children, I guess, as well. So, if you have comments about that or thoughts about that, you think of other places that an individual is that needs a support like this, please put that in the question answer box. Again, they have to experience a pretty cute behavior for us to, fill a bed with this, fill a bed in this specialized home, and have a documented history of, what have you tried before? If you they haven't been successful in our standard community placements, then perhaps they would be eligible for this specialized service. And it's, basically the same idea. Again, the referral would go through the case review team for approval prior to accepting or admitting or approving the service. But again, I'm going to pause. I would really like you to take the time to put some questions in the question box. Think about this and consider things that we may not have considered in our quick, rapid fire response to CMS. Just give you a second.
Hi, this is
Oh, hi,
Kara
Kara.
with
Sorry.
training. No, that's okay. I just wanted to let you know that there are some questions there, and if you want me to help by reading them out and kind of gather the themes and things like that, I could do that.
Yeah, that would be great, Kara. If we could just go to, I think I have one more slide. Maybe I have a couple more. And then maybe at the end, we could just do that for all of them. And we could start with the family hab ones and go to the group home ones. Would that work for you?
Yeah, that'll work great.
Okay.
Thanks.
Yeah, thank you for chiming in because I can't see you. I'm like looking all over my screens here. So rates for specialized homes. So what you will notice if you're paying attention on our websites is that under the Appendix K, we ask for permission to do this temporarily on a case-by-case situation. And we put a rate in there of $870 a day for specialized family home and specialized group home. And we did this by combining a group home and acuity rate, but I don't want to get caught up in that because I think for our purposes, we just needed to use established rates already to ask CMS for a temporary rate. And we felt like this might be a good place to start for some of our providers that might meet that credential to start working on what it would take to meet the credential. And if they have homes available, could we do this on a temporary basis as we build out our base waiver and get it approved and build our regulations for approving this in perpetuity or until we, end it someday with a better idea. But we did not include a rate in the base waiver amendment. And there's a reason for that. We can't put a rate in that doesn't follow the required regulation changes, and it requires regulation changes and a rate established through rate setting methodology. So for us to make this a permanent service, we have to do all of those things prior to putting it into the base waiver. And so it is under the Appendix K, it is not under the base waiver, and rates could change. Once we do the study and if we have homes that are able to set up under Appendix K and do it through this temporary period as we work on the proposed changes, we'll have an idea of sort of what the costs would be. That would be helpful. We're hoping that CMS will give us some a little bit of leeway there. Next steps. What are our next steps? So again, we will review your questions, comments, suggestions from this stakeholder feedback session today, and then we'll gather them all together. We'll review them as a team, and then we will submit amendments to our base waivers by November 11th, 2023. So we'll take what we can from your comments and determine if we can do it, how it would work. We'll put it into the November 11th, 2023. That is our drop dead deadline for them to continue to extend our Appendix K so that we can build these homes out in a temporary basis. Then we will take a deep breath on November 12th, and then we will go right into trying to build regulations and build out what we hope to be some standards for developing this on a permanent basis. And once that's done, we review those regulations and with the Department of Law and internal stakeholders. And then we open it up for regulations comment period for the official regulatory public comment and tribal consultation. So you will have yet another opportunity to comment on whatever regulations we create based on your comments in the next couple of weeks here. And we will then develop the forms, the processes, the trainings, everything we have to do to deliver the service or administer the service and implement it in the waivers. So as a reminder, I hope I haven't put you to sleep like this cute bear sleeping. My husband took this picture too. As a reminder, you can go to the webinar, click the orange button. It sounds like people are figuring out how to put the questions, answers in there. Please, call out if you want to be unmuted, and Kara and team will help us figure out how to answer all of your questions. And we can start that, I guess, now, Kara, if you want to.
Okay, sounds great. So what I'm going to do, thank you everybody for writing in your questions. We really appreciate that. You are also experiencing us answer some of them. We would also like to encourage you to put in your suggestions and ideas along with questions if you're inspired about what this presentation has covered, and you have ideas about people you serve or families and individuals keep it confidential, of course, but you can place your ideas in writing into the text area. What I'll do is I'll start at the top here, and we'll get our questions and in some cases our comments, since it's probably a good idea to share comments too. If you find that we stated a comment or question that you had, don't be shy about writing it in your own words, because it also helps us know that there's more than a few people who have that on their mind. We welcome duplicate comments and questions as well. So, okay. There were a few questions about off-topic problems that folks are experiencing. My best answer here is to, if you have concerns about a regulation or policy in other areas that you want things to be changed, email our policy team. We always welcome feedback. Of course, we're asking for feedback and stakeholder input on these topics, but if you have something outside of our topic, it's hss.dsdspolicy@alaska.gov. Maybe one of our team members can put that into the question or chat area for me. hss.dsdspolicy@alaska.gov. Okay, next, one of our first questions said, does a memory care unit fall into the area of specialized habilitation? Does this include memory care?
Not at this time. It wasn't something that we really considered, but we would take that under consideration for sure.
Okay. A couple of comments about family hab providers. There are family hab providers may also have other children living in the home. What kind of safeguards would be in place for situations like that? There were some suggestions about having different areas of the home that people would be living in, so that if there were children, there would be one area for their provider's own children, and perhaps a different area for people experiencing acuity. Any thoughts on safety requirements for family hab providers who might be this new provider type?
Yeah, those are very good, thoughtful considerations. I appreciate that. We have not sort of built that out yet, and it is a consideration because it, again, when we were sort of creating this, we were not thinking it being a normal sort of what our standard family habilitation unit is, which does allow children in the home. And so I think that's a thoughtful consideration of whether we would, because it really is going to be sort of, well, I think what we're trying to get to is a family type situation, meaning parents that would support an individual with shift staff and acuity. And it really, sometimes the individuals we're trying to maybe find a home for that are currently in a hospital setting or currently in API don't do well with other people. And so it would, you know, their needs would best be met if they were individually placed. So I don't think in those particular situations we would want to approve the service for a family that had other children in the home. I don't think that would be a safe situation when you have a person with a high level of acuity. But those are
Thank
things we
you.
should consider and also contemplate in our rules.
Mm-hmm. Absolutely. So keep on giving us your suggestions. There were a few comments and thoughts about a behavioral health specialist or clinician. People are looking for clarity around that relationship. Do they have to be an employee? Could there be a different arrangement? And then is it possible that it's a barrier because the behavioral health clinician would need to be chosen by the person getting the services? So would it be their choice, or would it be possible to establish a different kind of behavioral health service that just works with homes? What are some clarifications around that relationship of the behavioral health clinician to the home?
I think that's also a good comment. I think an individual has their own behavioral health specialist that they're working with if they have a behavioral health need, or they hopefully do. We're talking more about a behavioral health person that would assist the training and maybe work with the other clinician to develop a plan of safety for the home, for the staff in the home. And so we're looking for sort of the expertise to lend to each of these specialized homes, not necessarily becoming the individual's behavioral health clinician, would be my best answer. I think, you know, the other item that I didn't talk about at all here, which I will just throw out there, is that with our leftover American Rescue Plan Act monies, we have also requested some authority from our partners at CMS to use what was left from our direct support professional incentive fund. We had some money left, which we couldn't put back out to direct support professionals. And so we thought, well, this would also help us support this particular home. We have yet to build that out as well, still just an idea. But one of those ideas was to sort of build a council or build some expertise at a high level that would help all homes and not just the specialized homes. So for the specialized home to be able to get that rate for, you know, a higher rate for us to really sort of be able to justify that to CMS as that very specialized service, we would expect that from the agency itself to be able to support them in some way. But the ARPA funds we're talking about would be perhaps available to all homes to be able to access a service. And there also, we have talked about adding some money from that particular fund to be able to support building out a home again for someone that we currently can't find a placement for that is willing to support them, or they can't support them because they're very destructive to the property. They, you know, they might have some sensory issues. They need some different kind of a setup in the home. So we have yet to do that work, and that is something that we will also probably, I'm sure, be engaging with stakeholders on to sort of ask your thoughts on that. So there's a lot of things in play here, and really trying to figure out how to best meet the needs of individuals that really have some complex care requirements.
Okay, there's a lot of comments here that are positive about this being a very helpful service, and some concerns about it being difficult to access in terms of people that could access it or agencies who could provide. And then some concerns about, just like our previous question about behavioral health services in combination. We did get a look at the proposed rate information. Comment says we need a rate that would be an incentive to support people with higher needs, but not as restrictive to access as this sounds. So generally a call out for looking at rates to help people who experience more complex conditions.
Hi guys. I just wanted to let you know that we got some feedback that people who are using an iPad to engage with us today are not able to chat into the question box. And I want to apologize for that, because we really do want you to be able to chat into the question box and give our feedback. So I'm going to ask you that if you do have comments, please use the HSS DSDS policy at alaska.gov email, and please submit your comments and feedback that way. So if you're having any difficulty in putting in your comments or concerns and feedback, we really do want you to be able to give us this information, so email it to us. We did also get a request for the slide deck. They wanted to look at the slide deck later. Is that something that we'll be able to send out to attendees or have available to them in some way?
Yes, we will post this whole entire presentation on our policy YouTube channel. And we can also send out the slides. I have no trouble with that. So we can send that
Thank
to
you.
attendees.
Thanks, Delight. Yeah, we'll move through these questions, and then we'll ask if people, another way to participate today is to ask to unmute if you're on a phone or device, obviously with a microphone. You might be able to unmute and ask a question that way as well. And you're absolutely right. This isn't the only time and way to engage with us. We do our best to meet those needs, but always utilize the email and the different ways to make your questions and feedback, make us aware of that. Okay, some more questions. Is the intent for specialized group home and family hub homes to be a temporary setting for people until their needs are met and able to transition to a standard home setting?
I took myself off. Very good question. We have had lots of comments or questions about that internally, and I think the hope always is that people will become more autonomous and be able to overcome some of their challenges and live more independently. That's what our services, habilitative services, are all about, is trying to make people as independent and autonomous as possible. I think realistically, there may be some individuals that would benefit from this level of support for a lot longer in their lives. I couldn't even begin to say who they are or how that will work out. I think it depends on how successful we are with the support we offer, but I don't think that we're necessarily thinking we would approve the service for 3 months or something and then deny it. We're hopeful that we would work with those partners, whoever becomes a specialized home, to help build autonomy for the person for future case, that they could move somewhere else. But there may be individuals that stay there for longer.
Sure. Okay, thank you. A few of us are asking, is there an estimate of the number of possible people who could use these services? Do we have an idea of that?
I don't really have an idea of that. You know, currently, I would say we probably have, just off the top of my head, 20 people that in the last year, the last 2 years, have struggled and have gone out to community placement and then have returned to some type of an institution because they weren't successful. Those are the types of people that we're hoping to target to be able to be supported in this environment. That's why it would be sort of limited to how many providers that are available for this, and also that meet that higher credential, and also maybe you know, reserving the space for a type of individual that can't be served in regular at this time in their life. So I don't know if I really answered that correctly or, you know, thoroughly, but
as always, we're looking for your ideas around these concepts too. So if you have thoughts and suggestions around these,
yes.
Definitely share those with us. Here's a thought about staffing for people in homes. Staff, when somebody who experiences needs for complex support, sometimes it's hard to have enough trained staff. The person will often end up back in the hospital or in a more restrictive setting because there wasn't enough, or there weren't enough trained team members. Would providers need to have a plan in place for backups in order to create a stable setting for the person?
Very good comment. Yep.
Another related question, is the state looking at how other healthcare providers like API could provide support to community providers willing to create a program for people who experience complex needs?
Yes, we've had a lot of discussion about that, and I think you know, the Department of Family and Community Services has put some resources into trying to build a complex care type of team. And I think, you know, the thought is that perhaps they could have a position that would at least track, you know, some of the discharges from API. I think we're still sort of gelling on this and trying to come together between the departments. And, you know, I've been participating in the behavioral health roadmap for children, and, you know, a lot of conversations and discussions with providers and individuals in each of the communities that we've gone to so far. And I think there's a lot of work that we could do to create some sort of support. And that's sort of the idea I had for the ARPA funding, but I'm not sure how to build it. So if you have ideas for how to do that and how to make us all come together, that would be great. One idea that I will just throw out there, and I have yet to do the research on, is another state. I just recently returned from the Home and Community-Based Conference, the NASWID conference, and Advancing States, they're now called, sorry. And they were talking about a service that they implemented that they pay for with their waiver service, but it was really a call service for individuals that would call out to us. They have, you know, people that would sort of step in a crisis. So sort of like a health hotline or a health sort of call center. But they said it has been really helpful because those call centers that the state contracted with works with individual providers and works with behavioral health and works with their 988 response teams and their crisis now teams. And so that's something that I was hoping to explore to figure out, is there a way that we could bring that forward? And if you all think that would be a good idea or it's a horrible idea, whatever, please let me know. Put it in the chat. You know, if you want to talk about it later, be happy to do that. It's something, again, that's just an idea. We haven't gone down that path, but I hear what people are saying, that providers in our, especially our home and community-based providers, need a way to access competent professionals. Irregardless of the specialized type of home, all of our providers need that ability. And oftentimes our individuals would be served better if they could call someone and know that they had someone they could call, instead of going to the emergency room or having to wait to get their provider. They could call into this health hotline and get a question answered. I think it's worth exploring at the very least.
Mm-hmm. Thank you. Okay, more questions. There's a few of us asking if a specialized group home would also be able to provide regular group home, non-specialized group home to people in the home alongside specialized group home individuals.
That's a difficult one to answer, I think, and it's a thoughtful thing that we have to contemplate moving forward, because the same thing I said about the family home and having children in the home, it may also apply to these highly acute individuals that may do better in their own setting, or don't do well with others, or just need, you know, a transition period of not having anybody else in the home. So I think we have to consider that. And in some ways, putting it into the APK helps us do a case-by-case look at this to figure out what makes the most sense for this service going forward. So that's a very good question. I'm happy to hear what people say about that, or what your own comments are.
Mm-hmm. Another theme is about family rehabilitation for children who experience need for behavioral supports and or extensive medical care at home, ongoing care. Will there be, if family hab is very difficult to find, will there be a group home service for children?
I'm glad someone asked that question, because internally and with our sister divisions, we've had a lot of discussion about group home for children. And the department a long time ago made the decision that they didn't want to serve children in group settings. And, you know, times change, people change, and that has come to the forefront again a few times. When I was applying for the Appendix K and I wrote the stuff up, I had a call with the Centers for Medicare and Medicaid and talked to them about our asks. And I basically said, what we're really looking for is a specialized family hab home, a specialized group home, acuity add-ons, and the ability to add a group home for children. And they advised me, if you do that, you're going to slow down the whole Appendix K, because that is a very scrutinized and change in a service type that you normally have. So sort of the sort of negotiation that I did was to then say, how about if we take our existing group home and only in special cases that warrant it, we could reduce the age to 16. And the reason we chose 16, just to be very transparent, is in talking to Dr. Zink and other medical professionals, the physiological changes that a body has, when you're 16 years old, you tend to be more adult-like than childlike. we're not talking about your cognition or your ability to care for yourself. We're just talking about body structure. So we decided that 16, we could pass the red face test with our CMS partners, but pushing it beyond that is not something that we felt like we could do at the time. And I also think we want to be very cautious about that because, you know, children learn from other children. Children learn good habits and they learn bad habits, and we want to be thoughtful about that. So creating a specialized family hab home was our way to try to develop a service that we have in our current service array. We could add a flavor to that, but adding a group home would not have been probably very well received. And I don't know from a broader perspective if that's something that stakeholders really want, or it seems I've heard the question, so it's out there, but I want to be very transparent about why we did not include it.
Thank you, Lynn.
Mm-hmm.
A slightly different part of this topic, big topic. A few of us have asked, could we be more specific on who could be the clinical staff? Specifically, a few of us have asked, could they be a BCBA?
I don't think they could be. Well, could they be a BCBA? Is that the question?
Could they be a BCBA, or is there specific? Do we have ideas or thoughts or direction on specific licensing types that a clinician must have?
We do have those. I sort of summarized that in my presentation, but we have more information in the actual base amendment. So please go there and look at those. And if you have suggestions or comments, please give those back to us. So I'm not going to cite them off the top of my head because I took that out because I wanted to keep it very high level. But if you go in there and see those requirements and tell me if you think we should change that, or if it's too strict or it's too loose, or, you know, I don't know all the ins and outs, so it'd be good for you to look at that yourselves.
Okay, we're coming down. I think what we'll do is just maybe do 3 more questions and then we'll open it up to audio so I can pay attention to opening up the audio. Let's see, there are a few more themes here. Thoughts about training, specialized training for staff. Would the state provide training and or funds and or trainers for specialized training of DSPs?
Outside of the specialized service? Is that what we're asking?
I think
on a whole,
how do we support the specialized training for staff for these new options? Would the state provide training for them? You know, would there be? I mean, I know I can answer part of it is that training for staff has always been a concern, and we have our Alaska Training Cooperative working on quality training for staff. Some of these situations, training is probably better suited to the direction of the clinician in terms of responding to a person in everyday situations, and whatever kind of supports that person needs, that's going to come from the story of the person and how they work each day. But they're asking, you know, what's the groundwork around training for staff? Are there options? Is there something to expect or look forward to around that from the state level?
Yeah, I think you're spot on, Kara, that I think that's why we're requiring that level of clinician at the agency level, the certified agency level, because we want those individuals to help support and train. And I don't know how realistic that is, but I also think, you know, we used to do it. We used to have more agencies that had more of those specialized skill sets. And I've talked to a lot of providers about why that, you know, sort of went by the wayside, or how they've really tried to support it and they can't seem to keep it together at the level. And I think, you know, for us, for CMS always wants to know what we're training to and what the provider's training to for that particular, you know, subject or rate that they're receiving. So it's something we're just going to have to sort of tease out and figure out. I don't know. The answer to that, I guess, is
okay.
best.
That's okay. Just good questions to help people spark your thoughts and your
Mm-hmm.
ideas, because that's another, like we said before, it's another reason we're here.
Yep.
To get those too. Okay. Should we be expecting changes with assisted living licensing requirements that would have to be done before getting certified to be a new specialized setting like this?
No, because it's with existing licensure, the license doesn't change. At least not that I'm aware of. I think we'll have to carefully vet that with, as we make these permanent, we'll carefully vet that. But I think at this point in time under App K, I would say no, we're going to keep the current license and everything that's in place and just add certification pieces to it.
Okay. Let's see, one more theme. Generally, a lot of us are thinking about how there aren't enough homes to do this work already. Trying to find resources for people is difficult. Generally, my best thought on this is that we do want your ideas about how we could grow options for people, and we're here talking about this because we know that there is a need. So we are hoping to grow the amount of options available to people. Just know that people are thinking of that. You know, just there's just not a lot to pick from right now. So I guess that was more of a comment than a question. So, all right, what I'd like to do now is continue to please think of your comments that you would like to chat in using text. I would like to get those, of course, and we'll keep those on record and submit them as part of our big record set of our encounter together and our discussion. So nothing is ever lost if you chat it in and via text. I'd like to invite you to use the webinar controls to raise your hand. You should be able to see a circle with a hand in the middle of it on your taskbar within your webinar. And if you want to share by audio, ask a question by audio, go ahead and raise that hand. And I will do my best to unmute your audio. And as long as you have a device that is the microphone or a phone, you should be able to ask a question or share a thought by audio. So go ahead, I'll be looking for your raised hands. See that little hand with the circle in it, just hit that. Sometimes it takes a minute for it to work. So does anybody want to share by audio?
And I would just take this opportunity while they're raising their hands or letting you know, Kara, to actually thank all of the members of the training team and the policy team and our program teams here at SDS, because every little change that we make requires a lot of thought and contemplation and you know, trying to figure out what's a good product that we can even give to you to contemplate has taken us a lot of time because there's a lot of questions about this. And reminder, we didn't really have very much time, so we were trying to be creative. I have had I heard a feedback that we're just trying to create an ICF, and that is absolutely not what we're doing here. We're trying to create perhaps a step down or step up to that service to meet people where they are right now. And you know, an ICF requires a lot more things than we're willing to go down the path for. And so I just want to be clear, this is not what our intention is. Our intention is to create a specialized home for someone that needs it at the time, and hopefully be able to transition to a lighter, more standardized service.
Thank you, Lynn.
But thanks to all of SDS for their participation. We're taxing them with all of these things on our plates, so just shouting that out now.
Thank you. Okay, I have one raised hand. I'm going to go ahead and unmute you. This is Georgette. Go ahead.
Hi there. Hey, so yeah, just a question. What would be an example where the APK would be applicable for assisted living? An example of a situation.
Well, all of our services have to occur within an assisted living home. So the assisted living is the license. So the APK, these specialized services are for residential habilitation. So they only occur for individuals that are eligible for the Intellectual and Developmental Disabilities waiver, the CCMC waiver, or the APDD waiver at this time, because
Gotcha.
it's a specialized flavor of residential habilitation.
Okay.
Did that answer your question?
Yes, it did. Thank you.
Mm-hmm. Anybody else? Kara, can you still see my contact information slide?
I do.
So that's
okay.
the policy mailbox again below.
Mm-hmm. I have one other raised hand.
Okay.
Make sure. Oh, I have two actually. So let me grab the first one here. And this is Cheryl. Self-muted. You'll have to unmute yourself. There you go.
Thank you. Lynn, listening to this webinar, it really sounds like the model we use for nursing oversight may be a beneficial model to look at as far as the clinical oversight. Because honestly, looking at this, a home that's doing acuity, there's not that much difference financially to implement this with all the new requirements for the clinical supports.
Mm-hmm. So I appreciate that, and I think we could look at that model. You're talking about the way that we have the OHC or the NACOM nurse oversight set up.
Yes, because I think financially it's going to be a challenge for homes to provide this service versus acuity when you look at the numbers.
Mm-hmm. Mm-hmm. And individuals in this home, so this rate is for that particular provider to establish that level of clinical help. And acuity could still be attached to the individual. So that would be, the rate would be $870 per day for the home itself.
Okay.
To provide that clinical oversight, and then the person could also receive acuity if it's warranted.
That's very helpful.
Answer. Mm-hmm. That's the way we think we have it set up now. And we will talk about acuities and the need for some revised flexibilities with those acuities at a later webinar in November or December. But thank you. I appreciate that comment.
Thank you.
And we had one more.
Awesome. Thank you, Lynn. Yeah, we just have 4 minutes left, and I have 1, 2, 3 hands. So let's go for it. This is Lindsay. Go ahead, Lindsay. You have to unmute yourself. Go ahead.
Hi, thank you. So I'm a guardian, and so what are the requirements that I would need to, what are the conversations that I would need to have with the current assisted living home that my young adult is at to start documenting to see if she would qualify for one of these specialized homes? And then how do we validate that, say she's approved or the home is approved, that those services are actually happening? What can our involvement, or what can my involvement be as far as making sure that those clinical services and the quality of those clinical services are actually happening? And I plan to send an email, so look for that because I'll have a lot of questions. But we've looked into one-on-one care, and just getting that documentation was extremely difficult. So how do I push to make sure that this documentation happens to help support and see if my daughter qualifies for that, for these family habilitation?
Well, I don't know the particular case and don't know your daughter and don't know her circumstances, but this particular type of home that we're thinking about are for individuals that aren't currently able to be even supported at all in a standard home that we have right now. So I'm not sure if her needs are to this level. I would say, but going back to documentation, requesting or requiring documentation from a provider, they have to document what they're doing, and we could give you some of those documentation requirements from our quality assurance unit. So if you would just put your questions in and send those to us, we'd be happy to help run down the answers for you on all of those questions.
Okay, well, thank you.
Okay, thank you. One last one, and then we'll wrap it up. I'm going to go ahead and unmute you, Stephanie.
Oh, thank you. My question pertains more to the legal involvement of a lot of our recipients that are involved with API, usually, or not usually, I should say, often have a legal component that comes with them. Have we thought about how we're going to incorporate that when individuals go from there into one of these homes?
Well, we often have individuals that have some sort of legal requirement or criteria they have to meet that are in some of our home and community-based settings already. So I think we would consider it the same way we always do. And maybe there would have to be special consideration. I'm not sure of the particular cases, but that's why we really, these are sort of case-by-case scenarios of individuals that could be served in this specialized setting according to sort of the way we have it thought out. But I think we pretty much have to meet some of those legal requirements anyways. I hope that answered your question.
Well, kind of. I was just thinking more along that many have like a probation officer involved.
Yeah. Oh, so I see what you're saying. So I think from an interdisciplinary team that would work with within the agency. So say the specialized agency has this clinical team, I would think that they would have to work with the probation officer to meet the needs of the person in the home, if that's one of their requirements.
Okay.
But it is something that I think we're thinking about when we put this into sort of the service description, which I'm trying to sort of think about. We did talk about the ways that this clinical team would interact with the departments, maybe the API staff, with probation, corrections, and how they might interact there. I think would be important to note in the service description.
Okay, thank you, Lynn.
Mhm.
All right, we're at 1:31 right now, so it's a good time to wrap up. Lynn, did you have anything else you wanted to add? And
I just wanted to say thank you so much for listening, and hopefully you will take the time to go look at our proposed amendments and give us more comments. Happy to hear them, and reach out if you have ideas, thoughts, considerations that we haven't talked about today. Thank you for your time. Appreciate it.
thanks again, everybody. We'll be making our YouTube link available to you. And we can send the slide deck out as well via email if necessary and as necessary. Thanks for your time, and hopefully we'll see you again in our future webinars. All right. Goodbye for now.